So, okay, we got our recording button. Everybody click that. There we go. Okay, doke. So, let's get started. Dick, thank you again for the minutes and for the treasurer's report, which was sent out to folks. Any comments on that, Dick, you want to share?
Heather, you want to let me share the screen for? Okay, screen
There we
sharing. Hey, it worked. Wonderful. Well, as you can see by the treasurer's report, as of a couple days ago, our balance was about $154,000, thanks to all of the grants that Heather's obtained, and also such good support from the members. And this is just a further reminder that if you haven't paid your 2023 dues yet, it would certainly be appreciated, because we're spending a lot of that money now for the grants. Trish Farnham is working away on the essential jobs, essential care. So that's all going as expected. So are there any other questions or comments about the treasurer's report? I don't see any hands or irate faces or fists. So all right,
we're very glad.
We're
very glad to see it going in the right direction.
Yeah. Well, that's going up remarkably. It's going up, I think, $46,000 since just in the past year, with the grants and also a lot of good partnerships and sponsorships. And next, we'll go on to the minutes of the last meeting. Does anybody have any questions or comments about them? Just perfect as usual. Okay, we will not take a poll as to how many actually read the minutes. All right, I think that's concludes my speaking business today. So back to you, Mary.
Well, thank you. Well, Dick, I will say that since I wasn't at the meeting, I did read the minutes last time, and there certainly is a lot of good information in there. If you were not at the meeting, that you can pick up on. Also, the meetings are now recorded. They're all posted on the website for the coalition. So if you didn't have a chance to be there in person, you can always go back and look at them that way. Plus, all the handouts from meetings are also attached there too. So that's another good thing. Heather, thank you for making that possible. Appreciate it. So we decided a while ago to have our speakers at the first part of the meeting. Sometimes when they're at the end, we end up not giving them adequate time at the end. So we are real pleased today that our conversation is going to be about the role of community pharmacists in whole person care. And we've got my good friend Gina Upchurch, as well as someone I don't know. So Heather's going to introduce our panel, or our presenters, and tell us a little bit about what's going to be discussed today. So Heather, turn it over to you.
All right, thanks, Mary. Yeah, we are thrilled today. We are so lucky to have a great representation of pharmacists at the coalition, and I don't think people really realize the work that they do in communities and how holistic that is. And so we've got DeLon Canterbury here, and he's in Durham. He is the president and chief executive officer of GeriatrRX. And so he's a certified community pharmacy. I'm going to say it wrong, DeLon, pharmacology consultant, but he really has in his career been focused on low income seniors, those who are serving socioeconomic populations within the Triangle, who are, and also rural areas. So he is an alum of UNC School of Pharmacy, as is Gina Upchurch, who is the founding executive director, senior pharmacist. We all know Gina for her outspoken advocacy around this issue, and she is also serves on the public policy committee of the American Geriatric Society. So I'd just like to welcome both of you. I think we're going to start off with DeLon with his presentation, and then move into Gina's, because it's going to complement each other well. You guys have worked to kind of coordinate your remarks. Both of you I've made co-host in case you have slides. I think maybe Gina does. So you've been made co-host. So welcome, DeLon. We're glad to have you. I was excited that we were able to meet in person earlier this, I guess it was in the fall, at the Duke Caregiver meeting, and you're certainly making your rounds. So I'm glad we're able to hear more about what you're doing in North Carolina and nationally.
Yeah, no, I appreciate it. I'm honored to be here and to share the stage with my influence and muse and mentor, Gina. So good seeing you. But good seeing you all. Some of you may have met me a couple months ago at your luncheon. But hey, I'm glad to be back and share a bit more what I can do and what I feel our aging industry needs to start doing with de-prescribing. So I'm going to go ahead and share my screen. Okay. So happy Friday, everyone. I hope you all are doing amazing. We're going to go ahead and learn more about, what de-prescribing is, what is our aging industry facing, what are we seeing with the problem no one really wants to talk about, the med list. Why are there so many meds in our seniors, and how can we, as an interdisciplinary approach in care, address that problem? So that's what we'll dive into today. Please note this is mainly for educational and health and wellness purposes. But my mission, along with Gina's and everyone else in this room, is to save the lives of our seniors. I created GeriatrRX in 2020, really at the start of COVID, after really getting pretty frustrated with the way I felt we were taking care of them, and we as pharmacists were underutilized in the world of managing some of those meds. And so there had to be a better way of using our expertise and bringing it to people's homes. And so I created a telehealth de-prescribing service to treat people with this issue, but more importantly, help the caregivers who are at their wits' ends with an unlimited med list, and no one seems to be talking about how can we get this as little and low as possible. So we believe in not only looking at the med list, but I'm a pharmacogenomics consultant, meaning we help provide genetic testing with people as a tool to get people off of some of those medications as well. So some of you may have seen me as I started my business, got super involved with the African American COVID Task Force, and Gina's been a huge part of that as well. And it was a coalition of community stakeholders, researchers, Duke Health, clinicians, and other nonprofits focusing on really addressing vaccine hesitancy in some of our more rural and underserved populations. And that really propelled a lot of my confidence in public speaking, which I didn't see myself honestly doing. And that led to media attention, features with WRAL, Spectrum News, number of podcasts and radio shows, and international recognition in the work we do with the advocacy. And that was a piece I think I was missing in my life. Was I didn't realize that we can do so much more as pharmacists in a non-traditional role. So let's go to the beginning. My parents came from South America, Guyana. They were immigrants, and they moved to Brooklyn, New York, where I was the eldest of three. So you'll see my brother, DeLon, and my sister, Dacia, and my mom, Sandra, who's a teacher, retired now, thank God, and my dad, an accountant. And I was the eldest of three, but I was pretty much the shy one. I wasn't really the most confident like my siblings, but really always had a bit of a loving heart of service, and wanted to figure out how I can use that passion for healing and passion for my community. And that's what got me into the world of pharmacy. In fact, my parents, particularly my mom, was pretty much a botanist. She knew all the herbs, all the tinctures, all the teas to help with ailments. And that was what got me into the world of pharmacy and using the medicine to heal. So let's fast forward to the future, about 2010, 2014, when Gina saw me at my lowest. She was like, DeLon, how do you keep doing this? I was like, I don't know, Gina, I don't know, I have to. But essentially, this was my days as a Walgreens pharmacy manager. I worked all over the place from Henderson, North Carolina to basically the Triad, Fayetteville, and ended up having my home base in Durham and working at 24/7 store. I loved the community aspect, right? Like being in a community, doing HIV walks, going to career days, being a role model for students or future pharmacists that look like me, right? We're only about 5% of the population of pharmacists. So even though that felt great, I ultimately wasn't happy with the way I was just putting your name on a bottle and just barely giving all the care I could, and really just essentially giving you meds that are slowly knocking you out. And so eventually I got pretty angry and frustrated and truthfully very depressed with my career choice and what I was doing. I mean, how many of you waking up every day and just hated what you did? That was me every second of the day. And I mean, I just could not foresee myself living that life for another 40 years until retirement. So I felt like a true passenger in my life. I didn't feel like I was a true advocate. I was at a low. And truthfully, I think I was a part of the overprescribing pandemic, especially if you want to call the opioid pandemic what it was. We were in a high traffic of drug abuse in our town of Henderson. So I was constantly signing off on narcotics that I probably knew may not be have been the best for that patient's well-being. And they would even tell me, I don't know why they're still giving me this. It's not even helping my pain. So there has to be a better way. And I think that's where pharmacists can come into play. So what did I do? I stepped down. I got involved with the community. So I stepped down in like 2019, 2020, started volunteering, got involved with Gina's group on their formulary committee, helped with COVID updates. I joined on the COVID task force, got involved with the Community Health Coalition, and served briefly as a poison control pharmacist. And all of this, was done just because I felt like volunteering. It was fun. It was what I think was needed. And it helped me get that public health perspective of the impact we can have in helping people. And it allowed me to build a business that I truly love and enjoy. So pharmacists can do so, so much more. And we're tackling the issue of polypharmacy, prescribing cascades, medication side effects, drug interactions, gene drug interactions, all in our line of work on a daily basis. And so I believe a lot of our seniors are left behind when it comes to genetic testing. And this is a way to figure out which medications may be inappropriate based on how your body responds, not just a blanket trial and error approach that we currently do in our healthcare model. We believe everyone needs to have a comprehensive med review. So we're looking at all the herbals, all the over-the-counters, all the prescriptions, of course, and making sure that they're the right dose, they're right for the kidneys, they're right for you, they're right for your personal patient-centered goals. And we come up with ways to develop a deprescribing action plan with your provider. We do this as well as looking for financial barriers and trying to support and navigate any of those social barriers that may lead to your care. But ultimately, we're trying to use this as a concierge telehealth approach. So there's no need, I don't have an office, you can't just walk in and see me. Everything I do is virtual and we bring it to people's homes. So knowing that, I can't lie, our healthcare system isn't the greatest. About 275,000 people die each year just from mismanaged medicines alone. About 750 older adults are hospitalized every day in this country because of medication harm. And that costs us, the taxpayers, as about $530 billion we're wasting each year because we're not utilizing pharmacists and prescribers to really manage these meds or optimize these meds a bit more efficiently. So you may be wondering why my chubby cheeks are on the screen and my parents, but unfortunately, my grandmother was a statistic here who's pictured on the right. She had what was called mild cognitive impairment in her nursing facility and ended up being prescribed an inappropriate antipsychotic, which had actually worsened all of her dementia symptoms. So much so that the nursing home ended up saying, hey, we can't manage her. They kicked her out. And so my parents had to move her from New York down to Atlanta into their home and try to basically childproof the house to keep her from wandering. So very stressful. And it was a nightmare for my mom, basically seeing her mom waste away and did not know what to do. So they were stressed as caregivers. I wasn't quite a pharmacist yet, but all of this was because of one prescription. It took one Rite Aid pharmacist at the time upon a refill who found that this was the problem, called the doctor, demanded it be stopped, advocated for us, and eventually we got it tapered over a couple of weeks and she returned to her baseline self. So imagine how many people are falling through the cracks, right? How many people don't have that person advocating? How many people like me would have just refilled that prescription and not really think to ask the deeper questions because I didn't have the time or the system didn't support me to do that? That is the problem that I feel all of us have a role in addressing. And I don't think it just requires you being a clinician. Sometimes it's just asking the right questions and using your voice to advocate on a deeper level. I mean, you and I all know it. You see a med list for 20, 30 pills. Do you think that's normal? Like, do you think that should be normal in an 80-year-old woman? Probably not. And that's where I want us to get comfortable having a fair dialogue to change these perspectives. So pharmacists that especially are geriatric trained really have a passion for deprescribing, contrary to belief. We don't want people on a bunch of meds, but I believe it starts with all of us who touch seniors in having deprescribing education, some type of way to train your staff so that you're not wasting your time reactively treating a health condition or a fall or constipation that could have been avoided had we used better resources or better strategy of our staffing. And so I think as pharmacists, we can really quarterback the mission. And that's what I've made it a personal mission, along with Gina and the work she's doing, to make this the standard of care for all seniors. Unfortunately, guys, we don't have enough geriatricians to manage this. They're only about 1% of all medical doctors. Worse yet, they get paid the least. And so we're losing them. And now we're having more nurse providers and PAs, God bless them, but that they're not necessarily always trained in the world of geriatrics. And so we have an army of people that be taking care of them that aren't quite equipped unless they know what deprescribing is and how they can manage it. And so what we focus on really is training staff, pharmacists, nurses, PT, OT, long-term care staff on med safety, reducing these falls, reducing polypharmacy, avoiding these prescribing habits that keep leading to more and more issues, and leverage pharmacist expertise just by driving change. And a lot of it starts with policy and a unified mission. But don't take my word for it, guys. You guys are seeing the headlines, you're seeing the news. The CMS, the Office of the Inspector General, is basically saying we've got a huge problem, and COVID has not helped. We're seeing almost a 21% increase in the use of these inappropriate antipsychotics in these nursing homes, the same ones that my grandmother was in. So yes, I'm talking about the Seroquels, Zyprexa, Abilify, the drugs that we see inappropriately used to sedate patients. That's basically what they do. And a lot of it is attributed to, unfortunately, understaffing, lack of capacity, resources, lack of training, lack of a better way of managing dementia behavioral issues. But this has been going on for decades, guys. I mean, CMS made a report for this, a black box warning for these drugs since 2008. However, it's still worsening. So we can't say we're doing all we can if the numbers tell me otherwise. It's getting worse. And we know that our aging patients are living longer. So we all have a role in calling a spade a spade. So the AARP came in an official announcement supporting the renewed crackdown from our Department of Human Health and Services and their future audits for facilities that are using these drugs inappropriately. And yes, this came out just a couple of weeks ago. So the proof is in the pudding, guys. How are we preparing our facilities for these audits? Are you guys ready to lose your 5-star rating to a 1? Yes, they're going to change it to an immediate 1-star if they find patterns of inappropriate misdiagnosing of schizophrenia and bipolar disorder. And that is, unfortunately, the loophole we're seeing. So we're seeing people basically code these seniors in these facilities as having schizophrenia or bipolar, and they've had no history in their life. They just got newly diagnosed. So because of that diagnosis, you could throw on that Seroquel, Abilify, Zyprexa, those antipsychotics, and they don't have to report that to CMS. That is the loophole facilities use to basically chemically sedate patients. And that, my friends, is the problem. That is what leads to more harm. And there's an increased known risk of higher mortality, cardiovascular death, stroke, heart attack, and infections. So all of those, if you didn't notice, are more costly to the healthcare system, but worse yet, for the family and the patient themselves dealing with it. So we have a ways to go in driving change. So how are we preparing, guys? Like, what are we doing? Is your facility upskilled to understand the signs? We can't just no longer attribute dizziness, drowsiness to aging. That's to me is ageism. We got to look at ways to look at this a little more creatively. And is your facility prepared to really handle some of these audits that we're cracking down on these prescribing habits? So it's going to take a unified vision, of course, from the prescriber to policymakers to the nursing staff on the floor, right? We can't just keep slamming hot oil just because someone is wandering. That is inappropriate. That's not, and that's against the rights of nursing home residents. So the first step is really making sure your team is aware of what these side effects may look like in inappropriate antipsychotic use. Are you seeing increases of skin rashes, typo, rapid heartbeat, falls, over sedation, unresponsiveness? We can't let these drugs continue to mask dementia when we may be just having, I don't know, too many meds on a med list. So the proof is here, guys. So nursing homes now have to look out for these audits. And again, I mentioned whatever your star rating is, it'll be an automatic 1 if they find an inappropriate pattern with this. And I can't lie, guys, we're taking a hit in the senior care industry. We have the workforce shortage that occurred because of COVID in our nursing homes and in our assisted living facilities. We got hundreds of thousands of jobs that were lost, and we're still trying to stay afloat. So with your remaining capacity, how are you upskilling them, not only to keep them on board, but to make them aware of this so you're no longer wasting their energy treating something that, again, can be avoided with worsened dementia symptoms. So we have a shortage of senior care providers, but that doesn't mean we can't use the power we have to influence change. And really, every senior care business has the power to do this, all right? We got about 80% of all nursing home and LTC residents are given some type of psychiatric drug. Now, it could be an antipsychotic, but that also includes a new trend of anticonvulsants or anti-seizure medicines. So we're seeing people use that in addition to these, and that's what is attributing to this 80% number for people that stay in a nursing facility more than 101 days. And so they're using these chemical straitjackets. And when I get med reviews, I'm seeing on average about 3 to 5 of these, and they're wondering why the patient is, having memory loss or falling. It's sickening. And honestly, I don't want what happened to my grandma happening to a lot of the people in these facilities. And really why I believe deprescribing is in your power is because this is a mantra of value-based care, right? We're looking for lower costs. We're looking for better outcomes. We're looking for increased patient satisfaction, a better trust built between your senior care business and the caregiver and the family, right? We want them living longer and happier and healthy at home. That's the goal. So let's use the power we have to ask those questions with the right training to get people to prompt, hey, doc, do we really still need all this? And that's where I get the most joy. My biggest success is helping a family get off of 36 pills and get them down to 8 prescriptions. Another win was helping them stay out of a nursing home. Another win was helping them save hundreds of thousands of dollars because they no longer have to force their loved one into a memory care unit. That's the power pharmacists have. So imagine you just contract with a pharmacist or just have them outsource some of your work. And essentially you find ways to reduce costs on the back end. That is the goal, is to show that cost savings from our health intervention. And that's what deprescribing does. So who else can do this? Look, it doesn't just take me and Gina to do this. It honestly takes educated people with a will and a motive to make this happen. I've created a course where I'm actually training nurses, I'm training pharmacists, I'm training social workers, and eventually we're going to get some more PAs and NPs. But the goal is to get people talking about this. That's a lot of the work. But gerontologists are really well equipped to have this dialogue as they work with placements and receiving those referrals. I'd say the linchpin to this would also be geriatric care managers. They are completely important in this, and they can also further advocate for deprescribing. But geriatric pharmacists, this is our bread and butter, along with geriatricians. This is what we do. This is our expertise. So it's critical for us to leverage what we have and upskill them in a way that can really save your costs downstream. And in the long run, this will help our caregivers who are also wondering, why am I paying for these meds if I feel like she's getting worse? And that's what I see. I go to caregiver conferences, I go to national conferences talking about the same problem, over medications everywhere. So we got to work on supporting them because honestly, they will be our future aging generation, and they have the highest risk of substance abuse and other chronic conditions because they're so busy taking care of their loved ones. So it really does come full circle because we're hitting an issue that's going to be tantamount to our honestly quality of life down the road. So there's a lot we can do with de-prescribing, and I'm building an army of de-prescribing advocates with helping more of our seniors, improving that patient quality of life, and potentially building revenue because you offer de-prescribing as a service. But really, we don't have a lot of us using PharmAssist in the lens that we possibly can. And that's why I feel comprehensive med reviews are really being done enough to really help with this issue. So I don't want anyone, of course, to fall victim to overprescribing because of that near miss and the advocacy of that pharmacist. My grandmother was able to live another 7 years and lived to see 90. So this was the last day we had pictured with her. But I'm thankful because she remembered all of us. She was with it. She was making jokes. As you could see, she was smiling. We got her back, and I want everyone to get their loved one back, not see them waste away. So don't miss this opportunity. De-prescribing is such a unique service that it honestly starts with just, are you on more than 5 meds? Have you noticed a change in your loved one's prescriptions? And has anything come from that physically? Don't assume every medication is safe. And I'm including everything, shampoos, skincare lotions. Like, don't assume all of them are safe. So just so you know, I mentioned I did have that course. It's called the De-Prescribing Accelerator. It's a year-long program. I've trained, again, clinicians how to leverage de-prescribing, and we have an ongoing cohort. We just started last week. So proud of them. We've got a couple pharmacists and a social worker, but our alumni are nurses as well. So we really look to help everyone use the power of de-prescribing and put it into your business. So we do have ongoing enrollment. Just want to let you know that we do offer this. You will get one-on-one coaching on how to put this into place in your practice, and you will leave with a de-prescribing toolkit. So we cover everything from genetic testing, catching side effects, opioid de-prescribing for dementia, understanding the power of drug interactions with herbals and OTCs, and of course, preventative and holistic health. So with that, I want to thank you all for your time. Appreciate you, Heather, having me on board. And I'll give it to Gina. I answer some questions later.
Thank you. And I'm going to go, and then so if you have questions for Dr. Canterbury, DeLon, just hold them and we'll answer them in the end. I just want to say a couple things before I even get going with my slides here. First of all, amen, amen, and amen. Okay. So DeLon, I just want to thank you. And we say COVID did a lot of bad things, but I think DeLon exploding, like really talking about trust in the healthcare system and the importance of race concordance. I'll just be blunt about this. Okay. DeLon was volunteering here. We have a wonderful pharmacist. DeLon went in with the older Black man. We've been talking to him for years about something. DeLon talked, it's a whole different story. So it really matters that we are training people of color in significant ways so that they can be in our communities providing services. Because I may not reach somebody that DeLon will. And as well-intentioned as I am, and as our staff is, I just want to put that out there. It's called race concordance. I don't think that means DeLon can only see Black people and Gina can only see white. I don't mean that at all. But it does matter because we have trust issues but DeLon, you're doing a fantastic job. I would also share, and I don't know that I've shared this, and I don't know that I knew your grandmother's story, but I had the same exact issue. My grandmother in a nursing home, given an antipsychotic, diagnosed with Parkinson's, didn't have Parkinson's. Side effect, getting ready to get this nasty drug. I was just starting pharmacy school, did a little homework, got her off that. Okay, so
wow. No, I didn't know that. Didn't know that, Gina.
So it's right. We have shared that. The other thing I would just say, and I know DeLon could add to this, but community pharmacists are really struggling. DeLon and I are not usual pharmacists. Okay, I have a BS in pharmacy, did a residency in geriatrics. We are very unusual. We don't work in a retail setting. I did briefly. He did even longer than I did. But they are struggling. They've been told to get vaccines. They have more volume. They've been given less support. Many of them, some of the independents are struggling. You have vertical integration where, CVS is buying, Aetna, and Aetna's buying this practice and that. And pharmacists are little cogs in a wheel in a retail setting. We had to have a law passed in North Carolina to give them enough time to use the restroom. So So we just want to put that out there that community pharmacists are trying to do the good work in many ways. We're not a part of that right now, but it is a struggle for many of them to stay afloat. And if you think about it, some of what DeLon was talking about deprescribing. Well, think about community pharmacists. They're often connected to dispensing. So is there a conflict of interest potentially? And that's why you're seeing more pharmacists come out that are not a part of the dispensing, talking about deprescribing and medication appropriateness. It's just like saying you have a hospital that's supposed to do value-based care, but then they get paid to fill their beds. So we're in this weird time in the United States where we're pivoting to what we would call value-based care. We're not there yet because people get paid for widgets still.
Nope.
So just to think about that a little bit more.
Yeah, you triggered me a little bit, Gina,
Okay.
talking about the days of community pharmacy. I was like, I'm trying to get that out of my memory, but no, again, that's the reality we face. So I'm glad you brought that home.
Yeah. And two more things before I get going on my slides here is that, there's a real problem with, we were supposed to integrate electronic health records. They are so disconnected from dispensing software. So it's like you can't, I'm just using them as an example. They cannot even stop prescriptions. So if a prescription has gone to the community pharmacist to communicate, stop it. It's like an act of Congress. It should be super simple to stop a prescription. It is not. Miss Jones keeps getting those prescriptions she does not need. So we are working, we've had some work, and DeLon was part of this, and we just published in the American Journal of the American Geriatric Society. Now I'm gonna put a link in my talk about MedRec, getting everybody on the same medication page, providers, caregivers, seniors. And so we did some work and included seniors in that, and we came up with sort of 4 possibilities that we could work on in Durham, just as an example. Just been published, and I'll send you a link to that. But it's a real problem. You have this EHRs that aren't integrated with each other, and they're not connected to the dispensing software in many cases, and it's a real problem. So going upstream, DeLon and I can talk till the cows come home. But until you go upstream and fix systems, we're going to continue. And who benefits from this? We are one of 2 countries that allows direct-to-consumer advertising, New Zealand and the United States. You don't go to other countries and see this stuff. They are propping up our media. They are propping up politicians right now, the insurance companies and the pharmaceutical companies. So, that direct-to-consumer advertising, we take more medicines than people in other countries, as you just heard about. But they literally are what fund our media system right now. So, how are we going to shift that upstream? So I just want to sort of throw in those sort of bigger issues that I think matter. And the last one I'll throw in, because NCOA, I've been a member for a long time, and I know you all do a great job of advocacy. So one of the things that I'm concerned about, and a guy named David Grabowski is really leading the effort in skilled nursing facilities and in assisted living and in home care. And a group, I think it was the Commonwealth Fund, did a study, and I can give Heather the link to it, but they looked at who are the direct care workers in these places, and found out the significant number of them were not U.S. citizens or not even U.S. born. And we keep saying, tighten the borders, tighten the borders. Well, we know full well, if we don't look at immigration reform, we're not sure how we're going to handle long-term care settings, right? So it seems crazy, but immigration reform needs to be on the agenda for the aging community. And David Grabowski, if you want to read anything, he's really leading the effort. Okay, I'm coming down from my hyperventilation to share my screen. Just wanted to throw out some big issues there. So here's my slides. Start from the beginning here. Okay. So can you all see that okay? Super. So I'm just going to talk to you about what senior pharmacist does. And I do consider it whole person care. So I appreciate Heather's title. Just to orient us all to who are we talking about when we talk about older adults. And this is Medicare beneficiaries. So of course, we know it doesn't need to be just older adults. It could be adults with disabilities. But I just want to point out that 1/3 of individuals have incomes less than about 200% of the federal poverty guidelines. That means they're making, as a single person, a little over $2,000 a month. Okay. Another 1/3 have incomes just above that. So when we're talking about Medicare beneficiaries and we're counseling them about different things, it matters. sadly, race is a social construct, but racism, and I know we're talking about this as a coalition, really impacts what we're talking about because of redlining, because of all of our history of advantage and, quite frankly, generational advantage versus generational disadvantage. So when I'm talking to someone who, say, a Black person who has Medicare, is coming new to Medicare, their average income, these are averages, of course, so, or this is median, I'm sorry, this is median. So 23,000, whereas a white person is close to 34,000. But look at savings. And savings really matters, especially if you need to use something to fix your home so you can come home from a rehab facility, or home equity. Do you even own the home so you can adjust the home? So when we, I know as a coalition, we want to think holistically about who we're talking to. Don't make assumptions about what you're talking to, but realize the history and understanding that this has influence on people's ability to act in ways that they would like to at this point. Okay. So senior pharmacist does 4 things. What DeLon just talked about, what we call medication therapy management. Sometimes it's deprescribing, sometimes it's adding medications because things aren't being treated. But polypharmacy is a tremendous public health issue in the United States, which he just talked about. We directly pay for medicines. So we give people a card, like a credit card, they take to a pharmacy. Their Medicare plan pays first. We lower their copays. I'm thrilled to say we just increased our income to 250% of the federal poverty guidelines, and we just added all the insulins. So they're $35 now with Medicare D, but with us, if it's a vial, it's $5, and if it's a pen, it's $10 for all insulin. So we're adding more and more medications because the Inflation Reduction Act is helping in lots of ways. So it decreases our exposure as a secondary payer, and I'll talk about that in a minute. We also have 3 staff that are, 2 are MSWs, 1 is a master's in public administration. They provide people tailored services. It's really hard to ask for help. So if people are medication insecure, they're often food insecure, housing insecure. So we have people here on staff that can help them. And lastly, we didn't want to do this. We did not want to do this, but Medicare got real confusing when they added Part D and all the Medicare Advantage plans. So we are now the SHIP coordinating site for Durham County. And that's how we meet a lot of people. And we do Medicare counseling for any age, any income individual. So you'll see this here. We have a grant from the state, so we can do medication management for up to 300% of the federal poverty guidelines and not charge people. Financial assistance, $250. Medicare counseling, anybody, any age, any income at no charge, and then tailored referral. Getting at some of what DeLon talked about. So first of all, we have to balance these things. Medicines don't work in people who don't take them. Okay, Sir Everett Koop said that. So a lot of people do struggle to afford the medicines they need. Okay, so we do med management first before we pay for meds to make sure they need them and they're doing more good than harm to begin with, right? But non-adherence, often intentional. They couldn't afford it. They feel like they take too many. It's causing side effects. Okay, and cost non-adherence is tremendous in our country, even with Part D. Sometimes the best medicine is no medicine at all. You just heard a lot about that. I won't go into it. So our goal is really medication appropriateness and access at Senior Pharmacist. We do this work, we do those 4 things with 3 pillars. One is using motivational interviewing, trying to center what we do on what the individual needs and says they need. And in collaboration, we call our folks participants. They're not patients, they're not clients. They need to participate in the process. We use a racial equity lens as much as we can. And all the staff have to be trained in racial equity, but we talk about it regularly. It's a big part of what we do. And continuity of care. During COVID, we were able to get people home blood pressure monitoring costs, digital thermometers, masks. That's not in our mission statement, but it's a big part of what we do. And before I forget, Joan Pelletier is on this call, and she was my first and only ever boss, and she believed in Senior Pharmacists. So I need to give her a shout out for being an amazing and my only boss ever. So Joan, thank you so much for all the years of support to Senior Pharmacists and being a star. I call her the big cheese, by the way. Y'all can start calling her that too. I just wanted to point this out. Clinical care, as good as we think we are, we're not the big part of health. So what we call social drivers, I sort of scratched this word determinant. Social drivers of health are a really critical part of what we do. You all know this. This study came out before COVID, Loneliness is a huge problem for older adults, and it's compared to being obese or smoking 15 cigarettes a day. So fortunately for us, we're located in a senior center. So when people come in here, we try to introduce them to other things that they can be engaged in. We are the Department of Insurance's SHIP program for Durham residents, okay? So we spend a lot of time talking about Medicare and all the scams that going down with Medicare these days. We talk to people a lot about, do you want to be an original Medicare or Medicare Advantage? But this has led to what we call, all of this hoopla has led to what we call decision-making paralysis. And it leads to inertia. People don't do a darn thing because they're so confused by it all. So this is a little bit complicated, but you'll see over the years, the light blue is standalone drug plans. The dark blue is Medicare Advantage plans, the all-in-one plan. So they are growing in number. And the gold is special needs plans. So they're people that often have Medicare and Medicaid, or they're people that are in institutions. There are too many choices. It's called choice overload. And people often don't make good decisions about their insurance. And it can create not only that you pay too much for your medicines. That's like a minor issue compared to, you may not have access to your providers. You may not have access to good rehab services if you fall and break your hip. Okay. This is hot off the presses. So we just helped people during the Medicare open enrollment period, just over 1,000 people. For those in standalone drug plans, 56% of them needed to switch for an average savings of $776 back in their own pocket. The median was $441. It pays to compare. Okay, we help people even more that are in Medicare Advantage plans or that need supplements or that, but just standalone drug plans. Then if they were new to us or we'd never seen them before, 67% needed, 2/3 needed to switch for an average savings getting close to $800 and a median of $675. So that's a real chunk of change back in people's pocket. We don't just do Medicare counseling. Our pharmacists intervene 235 times over that 7-week period. And then we had a lot of community resources. The main thing is many of those people we saw in set appointments that we're now seeing them now. So follow-up appointments that have come from that. Again, we're in a senior center. We're in a county-owned building, but we pay rent in here, but we're so thankful to be in this building. Joan, thank you for getting the building built. We provide transportation, interpretation. We have bilingual partial staff time here. We do home visits for people who are homebound. It's eye-opening to go into people's homes. We do telehealth. We don't love it. We think it's hard. We love people coming in, and we can provide the transportation, so it's easier for us. Video counseling with Medicare is pretty good, but doing stuff over the phone can be a real challenge for a lot of our folks. After 2 years in our program, we decreased ED use and hospital stays by about 1/3, and it's been published in the Journal of American Geriatric Society. Some increase in medication adherence, but the thing I'm most proud of is that people, even though they're 2 years older, will rate their health as better. Okay. So here are some of our pharmacists. I play one on TV, so I'm not pictured here. And I'm just kidding. Okay, so senior pharmacist has access to Duke's electronic health record, so we can go in and quickly communicate with many of the providers. And we have smart phrases, which are just little phrases that make it easy for them to make referral. We are not a Duke program. We are in the community, have lots of non-Duke people that are involved with us, and happy to be as involved as possible with UNC, but that's how we get access to electronic health record. We have our own health record that we've created that create med records for people and action plans. We can, we monitor people to see if there are things that they can do around smoking cessation, good sleep hygiene. We monitor all that and put it into our own system that we have. I can't help but talk about this. Heather was here, but that's me hugging the Vice President of the United States. I'm just saying, I got to introduce her on CISA. She came here to introduce the Inflation Reduction Act and its impact on Medicare D. We were thrilled. And the people on the left-hand side are some of the advocates and participants who we had a chance before I went out to introduce her to spend some time with her and Shakita Brooks-LaSure, who runs CMS, Center for Medicare and Medicaid Services, and the governor and our mayor, as well as David Price, and got some time to spend with them and talk about the Inflation Reduction Act, which I'm going to talk about just very briefly. It's a huge impact on Medicare Part D in a very positive way. This year, $35 insulins. That's why senior pharmacists could help more, because now it's just 35. We don't have insulin that's 200 we're helping pay for. It's 35. So that's why we could cover more insulins, right? Manufacturer rebates. This is huge. It's hardly getting any publicity. So if a manufacturer raises prices now higher than inflation, that money has to go back to CMS. Okay, that's going to save Medicare D a ton of money. That is why the Inflation Reduction Act decreases our annual deficit. No, it decreases our deficit. It increases our income as a nation. Okay. And people, this is huge for people, especially with Shingrix and DTaP, so diphtheria, tetanus. They can get vaccinations at no cost now, just like Part B vaccinations. Those are actually through Part D, but there should be no cost for the individual for their vaccines now, which is tremendous, especially for people who need the shingles vaccine, right? And you'll see no cost sharing above the the catastrophic level beginning in 2024. That goes away, meaning people will spend about $3,700 out of their pocket before they don't pay anything. The following year, it goes to $2,000. That's huge for people who take expensive medicines, right? The other thing that happens next year is that people that have partial low-income subsidy will have full low-income subsidy. And that's going to be a tremendous gift to people. And premiums can't go any higher than 6% a year. In 2025, the Medicare D, 2026, they're going to start negotiating drug prices. That is actually starting now, but they'll be in effect in 2026, 10 Part D drugs, next year 10 Part D drugs, then they start adding a few more, and it's cumulative, and they'll start adding some B drugs with that. I'll tell a funny story. When the vice president was here, and Shakita Brooks-LaSure was sitting catty corner for me when the vice president was speaking, and the vice president was like, and we're going to control drug prices, and no. And I leaned forward to Shakita Brooks-LaSure, and I was like, good luck with that, because she's in charge of it, right? And she just burst out laughing, like, it's going to be an uphill climb. It's a lot. So I just wanted to point this out. This is tremendous. This is beginning in 2025. The individual may have a deductible, where they have to pay the full amount, and then they pay 25% until they spend $2,000. But the big deal about this is who's responsible in the catastrophic level. It used to be Medicare paid 80%. Look what's happening now. 60% the plan has to pay. So now there's incentive on these insurance companies to keep prices down instead of up, where they and the pharmacy benefits manager have just made a lot of money. And then the manufacturer has to give discounts of 10% and then 20%, and Medicare only is in charge for 20%. So this is what's also decreasing our deficit, the way they've totally rearranged the drug benefit. And it just sort of flew under the radar, and it's tremendous impact. Okay. Lastly, I just want to talk to you about what we're doing statewide. You allowed me to come here about a year and a half ago and talk about statewide survey that we had done, what's happening and what across the state related to paying for medicines, like senior pharmacists managing medicines, tailored referral, and Medicare counseling. So this is a heat map. And this is just we had 300 and some responses from across the state from agencies. So it's sort of a heat map of what they told us. So what we did was we took that and put out requests for proposals to about 50 groups and ended up choosing 3 communities to replicate senior pharmacists. So we have an NIA, National Institute on Aging grant through the Roybal Center on Aging at Duke to study, to help 3 communities. So the communities aren't getting money, but we are helping them. So senior pharmacist gets about $56,000. The Duke School of Nursing gets about $43,000. We are helping them over the course of a year replicate our program, and we are studying that. What makes it hard? What makes it easy? What facilitates it? What are the barriers? To try to study it. If one of them publishes outcomes that are similar to ours, it could be an evidence-based model through the National Coalition on Aging if we go through ACL. That's on hold now, applications for that, not from us, but from ACL. They aren't taking new evidence-based applications. But what that means is not new money, but it allows communities that have money to potentially take the senior pharmacist model and replicate it. So we are moving away from hard copies of our replication guide to an online tool. So we finish in May helping these 3 communities. We've been very fortunate. We've worked with stellar folks. It's a learning collaborative, so we're learning from each other. Buncombe does a great job with the MAHEC and the Rockstar Council on Aging out there. In the central part of the state, we're working with Guilford Senior Services, as well as High Point University and their pharmacy program, which is very driven group of people. And then out in the east, we're working in Pitt County with Access East, which used to be CCNC, and Campbell School of Pharmacy and East Carolina University. So we're super excited to have these community partners. They've been very good at giving us feedback about how to help others. And, you know, I had mentioned earlier that we just did this study working with some colleagues at Duke and in the Durham community about medication reconciliation and why is it so difficult. And we don't mean when you're in the hospital, getting everyone on the same page, not while you're in the hospital, not when you're coming out of the hospital. That's called transitional care. We're talking about just Ms. Jones living in the community. She's got this specialist over here, that specialist over there, this primary care. They're not on the same electronic health record. Even if they are, they don't communicate well and the med list is always wrong. Like, why is that? It used to be some of the nurses could adjust things in Duke's electronic health record. Now they can't. You know, so we're looking to think of a new care design model, and also looking at having the MAs be involved more and take ownership, because they're often women of color who are talking to people of color in Durham. And it's like, why are they not more engaged and rewarded and paid for to be part of this interdisciplinary team? And we're also trying to get the indication of the medication to always go on the label. And that's an act of Congress, apparently. So we're working on it. There's some national interest in that. But that article is available now online for those who want it. And I'm going to stop sharing so that DeLon and I can take, oh, I went over, sorry. We can take questions. Thanks.
Okay, what questions do folks have? Well, Gina, your enthusiasm is still as evident as ever. And DeLon, you obviously have gotten the Gina bug and have the same enthusiasm. So
I get his bug. Are you kidding? He's inspirational. Yeah.
we appreciate all of you both for doing and know that you're making a big difference in your communities and also across the state and what you're doing. I think it's really exciting what the Inflation Reduction Act provisions are, and that's got some big promises there. I think we're already seeing the insulin benefit and other things, so that's great at this point. So questions from anybody on anything?
I will tell you, I just heard, and I haven't seen the details of it, but I just heard last week they announced some guidance to potentially have Medicare. And I don't know if this is just in a certain area where at least 150 generics will go down to $2 for all Medicare beneficiaries. So you know, the $4 drug list at certain pharmacies, Medicare is thinking of doing that across the board for people. And that'd be tremendous. So that's, you know, to be determined who, what, why, when, where, but that would be big.
Gina, there's a question in the chat. Someone wants to know about where your funding comes from.
Right. Great question. And you can actually go to our website, seniorpharmacist.org. I'll put it in there and you can look at our annual report and see everything. We're very transparent about it. Great question. So we do have some contracts for funding. I told you the NIH contract. We have some money from the Office of Rural Health through the Community Health Grant process. We get more than a third of our money from individuals in the Durham community. So foundations, a lot of smaller family. We had big foundation support, but that was for a special project. Now it's a lot of family foundation, community groups, faith groups, businesses, local businesses that support our work. So we balance this charity care model, which gives you flexible dollars to do advocacy, honestly, and some other things, versus these contract dollars that are very much earmarked and that kind of thing. So we have a real plethora. Our budget's just over $1 million a year. And most of our money goes to staffing and of course paying for meds. So great question.
Of course, your program's been around for a long time, but I know also you guys started with a very small shoestring budget and over the years have been able to broaden what you do as well as your funding sources too.
Yeah.
So that's great. You know.
And I will add, I would not be here if Gina's company didn't exist. Her company gave me the model for geriatrics. It gave me the mindset to think out the box and use a social work interdisciplinary approach. And I felt, why isn't every pharmacist doing this? That's like the immediate thought. So I really have a lot of admiration for her.
Oh, Lord. Oh, that's the biggest compliment I've gotten. That's thank you, DeLon. Thank you.
I would just say that, been an old warhorse around for the years, coordinating many training sessions, probably one of the best training sessions we ever had done, and that was best received by local service providers was on polypharmacy. And I think most folks didn't realize the extent of the issue and how, as community folks, they could have an impact on that. So I'd encourage us to think about how we can do more things along those lines too, that really, impact people where the pedal hits the metal.
Yeah, yeah.
Important.
DeLon, do you see that question about DNA testing? Yeah.
Yeah, sure. So in the beginning, well, let's just put it this way. DNA testing, when I refer to it, is focusing on medications and interactions with your body. I'm not talking about an ancestry and me test. That's another type of test. But essentially what I'm looking at is a lot of the medicines we use for pain management, mental health, statins, cardiovascular drugs, blood pressure, some of them have a genetic component, and all of us may have different backgrounds, meaning I may be able to break down the drug where you can't. And that means you may have side effects, you may have more risk of harm. And so genetic testing or precision medicine, personalized medicine is a way where you can get a cheek swab delivered straight to your home. In about 2 weeks, I'm able to get a report and cross-check it with your med list. So that gives me more evidence that tells me, hey, based on this, you can't break down tramadol or codeine, and that's why you're getting hives. That's why you're super tired, where some people need to take 10 of them to get the same effect. And there are genetic components that a lot of our medical society isn't using in practice. Duke is using it, but in silos. The VA is using it, again, in silos. UNC uses it for like one drug. So we have a lack on the community end that isn't aware of this, and our seniors are left behind because this maybe came out in it's been around for about 20 years, but it's really gotten cheaper and more affordable in the last probably 5 to 10. So it can cost anywhere from, if you have original Medicare, it's completely covered. If you have Medicare Advantage plan, there's usually some type of copay with a prescriber writing it for you. Out of pocket, it could be anywhere from $150 to maybe up to $700. Okay, and that's for a kit to be delivered and you get the results. So I consult around that. I provide that service really anywhere. And to me, it's an equity piece, right? We have a lot of drugs that come from, honestly, 1970s data with primarily white males. And we can't say an Asian person or a Black person or indigenous will respond the same way. So that's where I feel genetic testing can be kind of an equalizer in seeing how these meds are actually acting in your body. And that's my business.
I want to get to Ms. Williams-Stover's question. I think, are you talking about senior pharmacist barrier or something else?
Thank you. You mentioned one solution of having nurses. You said NAs, and I'm assuming that was nursing or a personal care assistants.
I meant MAs, medical assistants, which is what they're called here if they're in it, but yeah.
Okay, I guess I was thinking about seniors who are dependent upon their family caregivers, also nurse assistants, being part of the solution, and wondering what are the barriers to helping both family caregivers and nurse assistants have more information and play a role in helping seniors and others understand this piece of the puzzle.
So I would argue we absolutely should be doing that. And I think DeLon's training is somewhat earmarked for those folks. So you do have this plethora of people involved. The problem, with a lot of this so first of all, pharmacists are not providers. So we can't bill. Now, if you're a clinical pharmacist practitioner in North Carolina, you can bill Medicaid. There's some very specific things if you go on and get this extra sort of thing, but we can't bill. We do what's called incident to billing. So we can be a part of a practice. You have to be embedded. Maybe you do warfarin counseling or you do diabetes counseling with an endocrinologist, but we can't bill directly. There are certain value-based services like annual wellness visits. In Buncombe County, a lot of pharmacists are very involved in that, or continuous glucose monitoring. Some pharmacists are getting that. So they can be part of a team that makes some money. But the biggest issue is that a lot of times, you know, not only are pharmacists not paid, but the CNA, they're not, that's not been given, it's control. Like it's, and what we're saying is the basics can be done by lots of people that we train, but we need to reward them and honor them as part of the team and escalate it when it needs to be. Yes, to the provider if it needs to be. Yes, to a pharmacist to do a more detailed, complete med review if need be. So there needs to be an escalation process so that the CNA, CMA feels comfortable, but they're trained and rewarded. And nobody's paying for that right now, as far as we can tell.
Good point. Good point.
Yeah.
Well, thank you both. Excellent information. You both are very passionate about what you do. You make a big difference in your community, and I think here in North Carolina and nationally too. So we appreciate all you're doing. And if you certainly, I'm sure you're going to make your slides available to Heather so that she can share those after the meeting also with folks. So thank you again for your time and being with us today. So Heather, going to turn it over to you. We're right on time for the updates from the coalition.
Gina and DeLon, that was so good. I'll spend my time, I'll do a few updates on the things that I've been doing since January, and then have an opportunity to turn it over to Trish Farnham, who's going to give an update on our work with direct care workers. And I think, you know, it's interesting that comes up in every single conversation. And so even talking about pharmacy today, I was glad to see everybody kind of glam onto that, because it's just critical in terms of the backbone of long-term services and supports. And then we'll have our health equity update. Laura Slovak's here today to do that. So I hope over the last month that you know, things have certainly been busy. The coalition has been representing the needs of older adults in the APS redesigned through the Division of Adult Services and the coalition, Dementia Coalition. Also, we had Rebecca here last month from the Division of Aging and Adult Services, and she talked about the multi-sector aging plan. And so I'm excited that that is continuing to move, and a leadership group has convened, and so there are beginning work for that multi-sector aging plan. And so both Mary and I are part of that work group, and Mary is co-chairing it with Joyce Matthews Smith. So great movement on a lot of just the internal policy work and collaboration. I had the opportunity after our last meeting to be on January 25th, part of a fireside chat with DHHS on mental wellness, aging, and caregiving, which was really great. It was with Dr. Betsy Tilson and Victor Armstrong, and it had incredible reach. And so more than 12,000 people were watching or on the phone for that event, which was really daunting, but glad that it got such good reach. It's on YouTube. It's had over 500 views on YouTube, and I'll share that with the group. But great information there, and I think an acknowledgement that they needed to do more on mental health and aging. So some eye-opening, and that was exciting. And then also on February 10th, we were partnering with NC Alliance for North Carolina Alliance for Health and Food Insecurity and Nutrition. And so on February 10th, we did that, and it was a great panel. So super excited. Next month, I'll be presenting at American Society on Aging Conference in Atlanta, doing a couple of presentations on our direct care workforce project that we had with PHI. So another good opportunity for us. A large portion of what I've been working on is with our not only the General Assembly and spending time up there, but working on our Legislative Advocacy Day, our day at the legislature. So I will touch more on details about our day at the legislature towards the end of the meeting when we get together with sharing our updates. So folks who are going to be going to that will have more details on what we're planning and how that will look. But I will say our work in caregiving, if you guys remember, we have a 1-year $15,000 grant from Community Catalyst to lift and elevate caregivers in the policy arena so that we can have people with lived experiences participating in policy. And so we've got these great caregiver champions that we've been working with and preparing them and really developing them in leaders through training. We have had a videographer, John Camp, do videos of each of their profiles, and these are caregivers across the lifespan. So if you remember, we're partnering with the Serious Illness Coalition. We're also partnering with the Children's Complex Care Coalition of North Carolina. So these are caregivers across the lifespan, and we have profiles of them talking about who they're caregiving for, what are their challenges and what are their hopes for North Carolina. And then we have a montage that we'll be releasing that's about 12 minutes that really kind of puts together these themes. So it may be around work, it may be around home and community-based services, it may be around education, but they're really quite compelling. And all of this is to build up to North Carolina Caregiving Policy Summit that we'll be holding in May. And those dates are going to be May 10th and 11th. It's a virtual event. That'll be an hour and a half each day. And what we are going to be doing collaboratively in the planning, we're letting our caregivers lead this and telling us the topics that they want. We are letting the caregivers facilitate the conversation and then bringing in experts to fill in the gaps. But it really is a caregiver-led experience, but with a policy focus. And so things are moving around really good. That grant will be over in May. And so we are winding down. It's kind of our big hurrah. And just pleased to have the opportunity. And as part of that, I'll say North Carolina has been able to be part of the national technical assistance, for lack of a better word, to learn from other states who are doing this and where their caregivers across the lifespan and caregiver coalitions have developed to engage caregivers. And so Karen Apart has been the co-facilitator, but she carries a lot of weight, and I'm probably the slack one of the co-facilitators, but she's done a phenomenal job. And so I'm excited because I think that this could lead for some additional work in this space for the coalition and other partners who are really focused on looking at caregiving with a lifespan focus and how that brings all of us together more than it pulls us apart. With that, Trish, I'm going to turn it over to you because you've been very busy with Direct Care Workforce, and I hope most of the coalition members here have been able to see what you released with your first e-resource, which was exciting, but you've been doing a lot more than just putting together a newsletter.
Oh, hi, everybody. Thanks, Heather. So for those of you I haven't had a chance to say hello to, my name is Trish Farnham, and I'm very, very excited and humbled to be with the coalition. Heather and I go way back, as do Mary Bethel and I, and it has been really exciting to be a part of this just essential effort related to supporting the direct care workforce in North Carolina. I have a fairly, I think, extensive professional career at this point in long-term services and supports. And ironically, I still feel very much like an intern in this particular space. And that's not because of a lack of direct experience in supporting direct care workers, but it is a testament to the nuance and the complexity of adequately supporting direct care workers. It has been such an incredible learning experience over the last several months, and I have been very, very grateful for so many people who have helped me get my sea legs in this space, and then really become trusted advisors on this really important topic. So in case this is helpful, just a little bit of background. I am working concurrently under 2 grants, as Dick alluded to earlier. Heather and the coalition had great foresight and have secured 2 grants to support this the coalition's strategic priority related to direct care workforce issues. And so I work under the Z. Smith Reynolds grant. And under that grant, my focus and the coalition's focus is really to elevate and amplify a lot of the incredible work that's happening in this space, just to make sure that the interdisciplinary nature of it is fully appreciated, that the different populations that rely on the direct care workforce have access to information that may be happening in one particular part of the population. So making sure that those of us who are supporting people in the older adult community are aware of maybe what's happening in the developmental disability community and vice versa. And that's where our first e-resource publication kind of came out of. And so I'm going to share it right now. Hold on a second. I don't walk and chew gum very well. So you should have it now. If you didn't receive it directly through the email release, please just take a look at that link and we'd be happy to add you to future communications. So wanted to make sure folks were aware of that resource. That resource will be published monthly, and because it is very new, we would love, and I would love to have any feedback you all have about information that you find helpful or information that you would find helpful. We do want it to be kind of a compendium of information about what's happening in the space, which is a very, very active space right now. I want to give a big shout out to several colleagues on who I don't see Adam on the call, but Adam with the North Carolina Healthcare Facilities Association, Kezia Scales, PHI, and several others really provided some great information and resources that we included in that particular publication. So appreciate that, and I'm very grateful for the collaboration. A couple of other things that we're kind of doing in the elevating and the amplification space really relate to some of our advocacy work. And because of the great partnerships and relationships that Heather and Mary and the coalition have always cultivated with other people, we have been invited to participate and present at various opportunities to, again, lend our voice to this much broader conversation and advocacy effort around direct care workers. So in March, we will be publishing an editorial in partnership with Care for Carolina and also our colleagues at the Domestic Workers Alliance about how Medicaid expansion will assist and support the direct care workforce. And also using it as an opportunity to really showcase some of the other healthcare inequities and disparities that exist beyond just the Medicaid expansion population. So we are putting the final touches on that. That should be released in the next couple of weeks. It's going to be on the Care for Carolina timeline, but we're excited to be partners in that effort. And a big shout out to Dick Chady for some of his wonderful journalistic research. So thank you, Dick. Really looking forward to finalizing this and getting that particular word out. A couple of other things. Heather has long presented at the Medicaid's Medical Care Advisory Commission, which meets quarterly. And I will be presenting to my former colleagues, which will be a little daunting later in March. And so really appreciate some of the work and the policy priorities that we will be updates that we'll be putting together for that. And so be on the lookout maybe for some requests for feedback on a few things. Many of you all may be getting emails from me as we prepare for that particular presentation. The other thing that I'm kind of excited to highlight is, again, referencing back to that earlier note about the cross-pollination opportunities that exist, and really nurturing the relationships that have already been forged between the different populations that really benefit from the direct care workforce. And so over the last several months, we've been cultivating relationships with our colleagues in the DD community. As many of you all may well know, the North Carolina Council on Developmental Disabilities has put a lot of energy and investment into what is termed the direct support professional position in North Carolina. And there are a number of efforts brewing that may have legislative impact and wage impact. And so we're following that. We're part of those conversations, and it's been a really exciting collaboration. The other dimension of what I get to do and what the coalition gets to do in this space is under the We Care grant. And you all may be, again, familiar with the We Care grant, but in partnership with Duke University and App State and the National Domestic Workers Alliance and with PHI, again, Kezia Scales, who's on the phone, we get to explore how do we improve the training and credentialing process for direct care workers in North Carolina. How do we build off earlier efforts to unify and standardize training, the training requirements in order to create a more streamlined pipeline for direct care workers, and then aspirationally tie credentialing to wage increases. So we've been working very closely with that team and with a very big group of stakeholders, many of whom are on this call or maybe on this call, to really examine how do we create a framework that is viable and built and based off of the previous efforts in our state and nationally. So we're really excited about that work. That work is really just getting kicked off this year. And we're excited about the developments under that grant so far. So I think that is the extent of my update. Heather and I agree that I'm going to start yammering to this group on a monthly basis. So if there are things you would like me to yammer about in particular, I'm more than happy to, or if there's a way you'd like me to present in future meetings, I'm more than happy to accommodate that. But I think that concludes today's update.
Thanks, Trish. That's good yammering there. And no, I just appreciate your work. I mean, I don't know, you're no intern in our book. And so just being able, I think, for the coalition strategically, it wasn't until 2020 that we had a full-time executive director. And so being able to, to Dick's point in looking at the budget, but we have been strategic in how we've envisioned growing the coalition, and it's through these strategic priorities like caregiving, like direct care work, who are so foundational to North Carolina's older adults as they age. And so I'm just really feel blessed that you are part of this team. We're a team now, and you're leading this effort because there's not a better person to do it. And so I hope the coalition and the members can see us grow in these spaces to do advocacy and policy work in ways that we now have a wider bandwidth and ability to do. So not only do we have the strength of this amazing diverse coalition and all of your expertise, but we're able to build staff capacity too. So it's super exciting. So thank you, Trish. And do get right, if you guys have things to submit to her around direct care workers or articles, resources, things like that, please share, because otherwise she's probably having to dig and look and find for it. But this is an opportunity for you to shine and highlight some things that may be going on in your worlds that we don't know about. Speaking of strategy and direction, health equity has also been one of those high emphasis areas that we've had, which I think is timely and critical. And the vast participation in our health equity work groups has been phenomenal over the last year and a half, really, that we've been able to engage members that haven't been engaged in our monthly meetings, but they come to the health equity work group. They've been doing research and really finalizing some of those priorities. So I'm going to turn it over to you, Laura, who is co-chair with Daryl Davis-Fulmer on our health equity work group, to give us an update and also give us your diversity moment for the month. So welcome, Laura.
Here, good morning, everyone. I just wanted to say thank you to Gina and DeLon and Trish for the really great updates and presentations. I think everything is just so well tied together at this meeting, and it's makes me really proud to be a member. At any rate, I wanted to give you some updates on our diversity moment. February is Black History Month, and I just wanted to give you a quick stat that it's also American Heart Month. And as a former cardiac nurse for 10 years, cardiology holds a place near and dear to my heart, no pun intended. But I just wanted to give you a quick stat that older Black adults do suffer at much higher rates of cardiac disease than white adults. So also another interesting factoid is the women and older adults present with cardiac symptoms much differently. So some women have presented, rather than the classic chest pain symptom for a heart attack, some women and older adults present with indigestion or jaw pain or shoulder pain. So just be mindful of, of that fact. March is also Women's History Month. That's next month. And So that kind of ties in with the women and older adults and American Heart Month. Just to give you also an update on our health equity work groups, we have had our final recommendations submitted from each of our 3 working groups. Just to give you a quick rundown, we met about a year ago and we broke into different working groups for the Health Equity Committee. We had a group focusing on BIPOC, which is Black, Indigenous people of color, LGBTQ+, and older adults in rural areas. And each of these working groups have used evidence-based research to come up with recommendations. And that recommendation could be maybe taking a survey. It could be a small policy recommendation. But these 3 working groups have submitted their recommendations to Daryl, myself, and Erica Janko. I just want to give her a huge shout out too. She's a PhD sociology student at UNC, and she's been a huge help in helping us gather research and whatnot. So the 3 of us met earlier this week, and we have kind of compiled everything into a PowerPoint to present to the board in March. We have those finalized recommendations, and we will be meeting in March to present that to the board. And our next meeting, which is March 10th from 9 to 11, we have invited Kimberly Strong, who's the executive director of the Meals on Wheels in Cabarrus County, to come do a quick presentation on food insecurities. We did find that food insecurities and lack of access to healthy food kind of transcended all 3 groups. So that we thought that would be a nice way to kind of tie in one of the social determinants in health we found that affected all groups that we looked at. So if you can join us next Friday, March 10th, we have it scheduled from 9 to 11, but we're trying to condense it down to an hour. So 9 to 10 would be our next meeting on March 10th.
Thank you, Laura. Great job. I appreciate that. And I would say if anybody else has suggestions too beyond March for those health equity committees, the work group, to have presentations, that's going to be a standing feature too, because then we know there's a lot of expertise. Pass those along to Laura or Daryl. So thank you. Mary, that is the updates from the coalition.
All right. Does anybody have questions for Heather, Trish, or Laura? A lot of good things going on.
All right. Are you
All right.
ready to move to legislative updates?
I think so. I was just looking to see if there was any questions in
Okay.
the chat. I don't see anything right off. A lot of good links in there that people have put in, so be sure and check those out as you're perusing things. So go ahead, Heather, and do the legislative update.
Well, and Mary alluded, it's getting busy over there downtown. And so there have been a number of Health and Human Services joint appropriations meetings the past 2 weeks, which really are orientation to the DHHS budget. And so full agendas, and they've gone over Medicaid. This week was one of those. Agency budget yesterday was Medicaid and DSOF, which is the state operated healthcare facilities, and Office of Rural Health, and then child development. So they've been very busy going through that. The House Health has met as well, and they ran a public health budget around communicable diseases that got moved through. So committees are definitely moving. It's been said that next week those committee chairs will get their appropriation amounts so they know what they're playing with. And that it's starting on the House side, the budget. And I think we've mentioned that before. So this year is for the House to start, and their real goal is what they're saying is early April, and to have a vote before Easter for that House budget. The governor has said that his State of the State will be on March 6th at 7 o'clock for his unveiling. And so we know after that, then it's likely going to see the governor's budget recommendations. So that will really kick things off then at the beginning of March in terms of being able to see his budget, then hopefully a budget there from the House, and then moving through the Senate. So committees are picking up, and it's a great I think the timing is pretty good for the day at the legislature. Next Tuesday, we were thinking it was going to be a little bit early, but we've had some release of some bills that I think are pretty exciting. I think most of you guys have heard about House Bill 76, the Medicaid expansion bill. It went through the House and now has been referred to Rules and Operations in the Senate. So yet to see what's going to happen there in the Senate, because I know that's been the sticky piece. Lots of other bills. I'll touch on a few, and I'll go through some of the House highlights first. House Bill 46, eliminating tax on government retirees, which is a government supported bill. House Bill 38, which may not have gained a lot of interest from all of you, but it's about entry fees into high school events. And it has to do with the senior Tar Heel card. So some of you guys might be familiar with the senior Tar Heel card. And in some communities, they give free admission. And so this would allow across the state free admission into those gates for senior Tar Heel cards. Various bills around property tax and veterans, eliminating the grocery tax is House Bill 15, a study to look at that. Just yesterday, we had the release of a CCRC acts, House Bill 170 and Senate Bill 145 around that. DHHS released revisions. It's a agency bill, House Bill 190. There were a few things there around the Division of Aging and Adult Services, around the state county special assistants. And also, you remember, we really led the way for the max reimbursement, eliminating the max reimbursement cap for adult day services. And there's a little cleanup there in that bill around what needs to be done on the social services grant side, so that adult day care gets funded through the home and community care block grant, and then the social services block grant. They have two different kind of administrative process, so that DHHS revision bill does address that. There's also several other things around central management and contracting, potential name change for the Division of Voc Rehab, which is kind of interesting. I don't know if all of our friends from the Serious Illness Task Force are here, but in the Senate bill side yesterday, Senate Bill 147 was filed, and that is around advanced healthcare planning directives, making it easier for people to go ahead and get those work done. It was done a bill was introduced in the last session, Senate Bill 66. This is a revision of that, trying to keep that up to date. Also, circuit breaker property tax in the Senate Bill 92, as well as medical transparencies and various other things. So I know that's all of you may be watching other things as well, but the bottom line are things are moving, and we're expecting to see definitely more filed. The APRN, or the SAVE Act, is expected to be released next week as well. So AARP has been working really hard on that, as well as several other groups. So I would take this opportunity too, if you guys are watching bills or had things that you wanted to share in terms of advocacy points in the legislature. And Mary, if you've got things you want to specifically address as well.
I was going to call on Rebecca Freeman with Division of Aging Adult Services. She puts out kind of a bill tracker. Rebecca, tell folks what you do and how they can get a copy if they'd like this. I think I saw Rebecca on.
She usually provides that, Mary, for the area agencies on aging and Governor's Advisory Council on Aging. Is that right? And the area and Senior Tar Heels.
Right. So look, she probably stepped away. I think she's still on, but she probably stepped away. But she does do a bill tracker where she basically identifies bills that are related to aging that and then does a link to them. You can get lots of information about the status of a bill by going to the page for the bill on the General Assembly website. So if you don't get a copy of this, maybe check with your area agency on aging or someone if you're interested in that. So Heather, any questions for Heather about any of the bills or things, or any of you that are watching legislation or have bills that you think are going to be coming up that you know about, that you want to give us a heads up on at this point, or any insight you have about bills that have already been introduced?
Now I see Bill Lamb, and I know he's working on some things too with some representatives. So I don't know if you're at a point where you want to share what you're expecting or not.
Well, it's one of these things where, you believe it when you see it. So we've been working on 2 bills. One would be to increase the personal needs allowance for residents in Medicaid residents in nursing facilities. Last year, the General Assembly did raise the personal needs allowance for SA residents or for residents in assisted living facilities and family care homes, but the personal needs allowance for folks who are in nursing homes is $30 a month, and it has never changed. It was set in 1987 and it has never changed. So we're hopeful that it's going to get introduced. The other is we've been working on a bill to raise the ratio of ombudsman to residents up to a national standard, which would mean we'd need funding for an additional 11 ombudsmen. The ombudsman's job has gotten more complex over time, and they're really portrayed as kind of the first line for response if there are any issues in care. And we need to have adequate staffing so that we can be responsible.
Yeah, thanks, Bill. A lot of budget negotiations are going on behind closed doors right now. And so if you have budget issues you're concerned about, now's the time to have your legislators hear from you. One, of course, that many groups are working on has to do with the direct care worker issue, as we've talked about earlier. Funding for nursing homes for direct care workers, as well as personal care service funding and assisted living that covers worker costs. That money, those facilities received a little increase with COVID funds and many of them use that money to increase the wages for workers. Well, that temporary increase is going to be going away. And that's a real concern to many, many folks because if that money's not there, then these temporary raises that a lot of workers got are not going to be able to be sustained. So I think that's something that most aging groups that I know of really have high on their wish lists of hoping the General Assembly will help to address that further this year.
And I'd say, Mary, it was really in those joint appropriations meeting for HHS over the various organizations, a lot of talk about direct care workforce, and that was definitely alluded to in a pressure point for the DHHS budget and the Medicaid budget, and the acknowledgement that work needs to be continued to do that. And then when the conversation around the state operated health facilities and the dramatic workforce shortage there, and those are state employees that are making $15 an hour with benefits, and they're really struggling. And so they had some dramatic numbers that they were showing those legislators. So I think that the topic is greasing the wheels there, because we know that's going to be a big focus.
Yeah, it's a lot of uniformity as far as the message that's coming out from folks about this is an issue that really does need to be addressed. So Heather, you want to share information also about the Legislative Advocacy Day?
I do. So on Tuesday, I'll drop the link in the chat, is the RSVP form. We're going to have a couple of things going down at the legislature on Tuesday, the 28th. So the coalition, in partnership with the Friends of Residents of Long-Term Care, NASW, Serious Illness Coalition, and AARP, are going to be first hosting a legislative breakfast. So at 7:30 to 9:30 down in the cafeteria of the legislative building, which is downstairs. If you were to enter the building from Lane Street with the big seal on it, you go through security, and the building is opened at 7 o'clock in the morning. So you'll be able to go through the main building entrance at 7:30, go down to the cafeteria, and we are going to be hosting a breakfast free to anybody who wants to come, thanks to AARP, with bacon and grits and all the fixins. And we have at this point set 56 people registered for the legislative breakfast. 5 senators, 12 Republican representatives have RSVP'd, and there are some really great names there. But we're coming together to talk about older adults, and so it's an opportunity to mingle and mix and talk with legislators about the various services and programs and challenges we're facing. So that will be a great breakfast from 7:30 to 9. People are free to kind of come in and out. We're not going to have a formal presentation, a little bit of an acknowledgement when we're all together, but nothing really formal. After 9 o'clock, we'll be moving up to the 1000 court of the legislature building. So there's 4 quadrants of that. If you were to walk in that main building, it's to the right. And we'll have a table there for coalition members. And we have handouts and materials for you to do a walk around and to go visit your legislators. So one of the things all of the groups that are working on this are focusing on is direct care work. So we have put together, and let me see if I can pull this up in my screen here. I don't know if this is going to actually work because I've got, let's see. You're seeing probably a bunch of my gobbledygook here. It's not going to be able to move there. I can move this bar. Okay. Oh, so I will say this before I go to the direct care workforce. So one of the things the coalition is doing for the week is in the cafeteria, there are placemats. Like if you were to think of a diner, how they have paper placemats or something. We are sponsoring a placemat on the aging of North Carolina to be in the legislative cafeteria for the week. And so Andrew McCullough, who's working with us as our intern for the year, has put together this infographic paper placemat that we'll be having. And I think that'll be a nice thing for the day, but the nice part is it will be in the legislative cafeteria for the whole week. And so everybody who comes in and out of that cafeteria will see that placemat. And then I wanted to showcase, this is going to be our leave behind for all of the groups, focusing on the direct care workforce. And so we have this branded document with the coalition and has some facts around what we know about the workforce currently in North Carolina, but also the dramatic need for the workforce in the future, in addition to the current crisis we have. And so our ask is really for the General Assembly to elevate the workforce crisis and to support some bold movements. And then on the back, you'll
Heather,
see.
we aren't seeing that. I don't know
Oh,
if
you can't. Okay, let's see if oh, well, it was looking really good. Let's try it again.
We saw your
The
file
placemat.
list.
Okay, let's
No,
see.
we saw the file list. There you go. Yeah.
Okay. Could you see the placemat?
No. We didn't see
Oh,
that
well,
either.
I'll try to go back to that. I'm going to stick with this since you can see it now. But anyway, this is the leave behind, the direct care workforce, but leave behind that we're all going to be using to provide some facts and background. And then on the back of it is a list of all the Coalition on Aging members, which is a phenomenal list, and it's getting harder to put on one sheet of paper, I will say. So, but that's
all the organizational members.
Yep. And then can you see this, Mary, the placemat?
Yep, we can see it.
Okay. All right. Well, good. I guess it takes 2 times. So we will all be trying to wear red. If people have red, we're encouraging people to wear red that day. We're printing up stickers for us all to wear that says Age My Way, North Carolina, to give us some uniformity. We will have list of legislators by county and district. So if you need handouts for yours or to find out where they go, we'll be able to team you up with somebody to get you there. We'll have maps of the space of the legislature, the full building, and also the legislative office building, if that's the direction you need to go. And then once people have made their visit and stopped by, you'll come back to the table, and we have thank you notes that you'll be able to write a thank you note, and also a little small survey that you can tell us who you visited, if you learned anything during your visit that might be helpful to share with the coalition about that issue or something else that, and then we'll be able to keep record of that as we work with them throughout the session. Again, I think it's just a great way for people to come together, to come to Raleigh, to show support. If you can make an appointment with your legislator in advance, that would help. But at this point, it probably is too late. But there will be lots of milling around, and you can always stop and talk to the legislative assistant as well, who will carry your message. I have never done one of these in person before. I'll just say in my time here, we've only done virtual ones. And so this is new learning for me. And I'm really thankful to Mary and the other members of the planning team that have been doing this for a long time and have been helping us along. But do register if you're interested in coming for one or both parts of it.
Heather, I would just say that it's a good possibility that the Health and Human Services Joint Committee, which is made up of House and Senate folks on appropriations for health and human services, it will probably be meeting on Tuesday at 8:30 in the morning. They're usually in room 643 of the Legislative Office Building. That is a wonderful time to be able to catch the members of that committee as they're going and coming to the committee meetings or even after the meetings. So if you happen to have one of your House or Senate members is a member of that committee, that would be a great time to catch them. So let us know if one of your folks is there, and we'll make sure you get the information, probably take it to you at the breakfast since those meetings start at 8:30. But these are always fun. It's a fun thing to do. People like to see their legislature in action. And I think legislators, for the most part, really like hearing from constituents and knowing that they're there. Also, the nice thing about it, if you happen to, want to make a day of it, the legislative cafeteria also does lunch too. So you could go to lunch there, or there are a couple of really good cafeterias or restaurants now that are in the museum buildings across the street from the legislative building.
And the cafeteria is not that expensive, so it's all good.
Yeah. Yep.
And I hear the bacon's really crispy. Chris Brandenburg from AARP and I were handing out invitations last week, it was last week. And really, people were excited about the bacon and these biscuits. So I'm pretty excited.
I can verify.
Yeah, there's an amen to that. Okay. Any other questions for Heather about any of the legislative things or the legislative advocacy day? Okay, well, good show. Heather's done a good job of pulling this together.
I will can I just make one comment before we go into sharing members with members? I have a couple of things I want to share, so I just want to go first, if that's okay, Mary, when you're ready.
Go ahead.
Okay. Suzanne LaFollette Black, who is on the board of directors of the North Carolina Association on Aging, asked me to just make a comment to let you guys know and remind you that the NCAOA conference is going to be in Charlotte, March 13th through 15th. Their registration is strong. They've got fabulous speakers, and I'll say that because I'm also on that planning committee and on the program committee, and Janice Tyler is as well. So Suzanne, Janice, I've been working on that program, and we've got Daryl Davis Fulmer, who's going to be talking about health equity. We have a speaker from Association on Aging, who's going to be talking about ageism, and then a variety of really strong presentations. So I think most of you have seen that, and it's definitely been in the update. And then I had yesterday an opportunity to go with Bill Lamb to UNC, see the Carolina Blue, to the School of Social Work's launch of their Center for Excellence in Assisted Living. And so it was an exciting launch. They're doing a lot of really bolstering the workforce and promoting evidence-based practices and policy towards improving assisted living. So many of you know Cheryl Zimmerman, who is really a linchpin in this project, but it's the Center for Excellence and Center in Assisted Living at UNC. So I saw Jeff was here too. But it's a national center, so it goes far beyond Carolina, and it has, from my understanding, been in existence for a while, but just has found a home here in North Carolina. So that was exciting. So those are the updates I just wanted to make sure got said as well. Thanks, Mary.
So anything else anybody wants to share? Any conferences coming up or personnel changes or anything you want people aware of?
Friends doesn't have a conference coming up, but we do have some personnel changes, and I'm pleased to announce them today. I think many of you know that Lauren Zingraf, our executive director, resigned recently to take a new position, or to take another position at the state chapter of NASW. But I'm here to announce that the person who left that position is now going to be working for Friends of Residents in long-term care. You all know her. It's Kay Castillo. She's on this call and has been very active in the coalition. So Lauren and Kay just kind of swapped jobs, but I think everybody's happy and looking forward to their new roles and new organizations.
And Kay's on the board for the coalition, so
She is.
we're just real excited to hear her new role too.
Hey, Mary.
Yes, go ahead.
It's David Rue with the North Carolina Public Transit Association. Appreciate everybody's good work across the state. Just two updates from us. One, we have our annual conference April 17th through 19th in Concord. Looking forward to that. We were in person last year and had a very strong attendance. Second, we're still very active in the Medicaid.
David, I think you froze up, at least on my screen. Can y'all hear him?
No, I think he's frozen, Mary.
I think he's talking about the Medicaid, the non-emergency transportation effort that's going on with Medicaid. Why don't we try to come back? David, maybe check your audio if you can, and we'll come back to you. I saw Twyla put in information in the chat about the SE4A, Southeast Association of Area Agency on Aging conferences in Asheville on August 27th through 30th. Twyla, anything you want to say about that?
Thank you. Good morning, everyone. So registration, we're still working on sponsorships at this point. So hopefully around early or mid-April, we'll have additional information, but you can go, and I'll put it in the chat, se4a.org, and you can just find a link if you want to just bookmark that for future reference.
Okay, great. Myra, we appreciate your comment in the chat. We're glad to have someone from law enforcement with us. So tell your colleagues, we welcome all of them.
Hey, Mary, it's Laura Lovell. I have an update if that's okay to share.
Sure, go ahead.
In my work at the Department of Justice, I focus on elder abuse. So I just wanted to share that the district attorney's office is having their elder abuse conference in Lake Lure this year, and that's May 10th through May 12th. And also the North Carolina Partnership to Address Adult Abuse is having their annual conference on Tuesday, May 23rd. We opted to have it only in person this year, and it's going to be at the Corey Auditorium at Guilford Technical Community College in Greensboro. So we try to also find kind of a central location. So those are the two updates I can share.
Super. Isn't it exciting about all these in-person meetings we're now having? So I think things are back in full swing.
We're really excited too.
David, are you able to now hear us? David Rowe? You're on mute. You're on mute now.
Can you hear me?
Yes, now tell us about that non-emergency medical transportation, which I think you were talking about.
Yeah, just very quickly, we're active in that space. You may recall the state went to Medicaid managed care back in July of 21 with the standard plans. Starting on April the 1st will be the next rollout, which will be the tailored plans. And that will be dealing with the population behavioral health. And they're a heavy user of transportation. So that rollout is happening April 1. And we're active in that space as well. And continuing to work with the health plans to make sure the members get the kind of quality service they need. Apologize for the technology. Thanks for the time.
So David, I know there were some hiccups initially with when things got started with non-emergency medical transportation under managed care. Are things ironing out pretty good from your perspective?
We're spending a lot of time with the health plans. It was better than the launch. We've been very active in that, and they've asked for our assistance to ensure that program continues to improve. There were two brokers, one call initially in the market, they left and they've been picked up by MTM, and then Motive Care is in the market with 4 of the health plans. But we're in very deep conversations. In fact, with Motive Care and the 4 health plans, we've launched a new pilot program in Johnston County in November, where the broker is auto-assigning all of the trips in Johnston County to public transit. And in that 3-month assessment, the success rate is 99.7%. And we are now looking to expand that through pilot programs with different sizes and flavors as a way to enhance the experience. But we continue to be active in it, and a lot of work to do, but we're continuing to forge ahead. Better than we were, a lot of work yet to go.
Well, it sounds like that Johnson County program has a pretty high success rate, so that's great to hear.
Yeah, we believe that can be a model for them to then replicate in other sizes and flavors and so forth. Real example with real performance. Thanks,
Great.
Mary. Thank you, Heather. Appreciate your leadership.
So I see DeLon put in the link for the Deprescribe and Accelerator course. So that's in the link. If you haven't seen that. I just wanted to mention one thing. Many of you remember Dee and Dick Hatch. They are pioneers and agent award winners for the Coalition on Aging. They are now have moved Dixon Nursing Home, and Dee is in assisted living in Hillsborough. So we just want to keep them in our thoughts. They still all want to know everything going on with the coalition, but if you knew them and you'd like to reach out to them, Heather does have their address and she can get that to folks. But just wanted to remind folks of where they are. Also, Polly Williams, who's another pioneer in aging. Polly is almost 100 years old now. She continues to live at home, and I will get Heather her address in case anybody'd like to send a note to her also.
I saw her at Christmas. I made a point of going to see her. She's still a rock star. Amazing.
She is.
Yeah.
She is. But not getting out a whole lot, and I think it's really she really cherishes visits and cards and things like that. But we certainly owe a great deal of debt to those pioneers for where we are today, for the vision they had in the Coalition on Aging, for sure. Anybody else have anything? Okay, Heather, anything from you?
No, I'll just let people know that next month on our meeting on March 24th, the presentation we've got lined up is from the North Carolina Early Childhood Foundation. So They sponsor Family Friendly North Carolina and do a lot of policy work around family friendly policies, and which are also critical to older adults and family caregiving. And they have developed a certified family friendly employer. It's a volunteer certification program. So they're going to come and talk to us about the work they do in the space of policy and employers, and tell us a little bit about this new certification program that comes up. So I hope people will join us for that.
Right. I see Heather also put in the information about the NC Falls Prevention March 3rd Summit they're having. That's in the chat.
Thanks. Yeah.
Okay. All righty. Well, going once, going twice. Anybody got anything else to add? So you get 4 minutes back. So have a good day. Thank you everybody for joining us. And if these materials will be posted on the website soon, if you want to go back, review anything or refer people to it who weren't here. So take care. We'll see you next month. Bye-bye.
Thank you.